BTOG, World Lung and ESMO 2021 in an hour. My name is Tom Newsom-Davis. I'm a medical oncologist at Chelsea, and I'm pleased to say also the Vice Chair of the BTOG Steering Committee. This meeting is made possible by including the good people of MSD, Takeda, Lilly, Boehringer Ingelheim, and BMS, and I thank them for their assistance. As you know, the people who run BTOG really are Dawn and Gina. If you have any questions regarding BTOG, if you're not, websites there, or use the email there as well. And skipping on to the next one, I would love to send a question here, and I can ask the questions of the learned panel. You can be brave and put your name and where you're from, and that's much more fun, or because frankly, it's the best bit. Please give your feedback if you can, and if you are collecting for your CPD diary, this is our. So without further ado, here is the agenda. This is me doing my welcome. We're first up in my expert panel is David Gilligan. David is going to talk to us about the updates in radiotherapy from World Lung and ESMO. David, thank you very much.
Very much. I shall be talking to you this evening about some of were at World Lung, ESMO, and also a sneaky bit of Estro as well. I think it's fair to say that there were 3 RCTs to talk about, but I think that a lot of the presentations that practice and some of the questions that we have in our MDT, some of the questions that come up regularly, and we'll go through them in the next few slides. So that might benefit from post-operative radiotherapy or PORT. And last year I had the pleasure from the LungArt study, which randomized patients to either post-operative radiotherapy or not, in addition to their N2 disease. And for those of you who don't recall, there was no difference at ESMO. Cécile Lipechou presented the patterns of relapse. And so that in this slide, at the top line, that mediastinal relapse, and that is perhaps not at all surprising. There was no difference really in any distant metastasis relapse. There were more deaths in the PORT arm, and you can see from the highlighted area that in the pulmonary toxicity, and there were also high rates of grade 3 and grade 4 toxicity as well. So looking at the patterns of relapse, and I thought this was quite interesting, on the left here, mediastinal relapse mainly actually less frequently in the PORT arm, but for right-sided tumours, the areas where you can see there 4R, 2R, and 7, but interestingly for literally 4R, which I thought was quite an interesting when we're looking at patterns of relapse in our patients. In terms of the prognostic factors for DFS, these are listed in the table on the right, and you can see involved N2 nodes, those that are involved DFS, and also not surprisingly the quality of resection. So R1 and R2 are not good things. This was a slide which I think probably illustrates the data most clearly and most effectively. That for the PORT arm, there's obviously much less mediastinal relapse, but both mediastinal relapse and distant metastasis seem to occur in the PORT arm. You can see that as time progresses 5 years and onwards, that there is an increased incidence of death. Look at why that is, and obviously the data that was shown is concerning for cardiac anything that really, there were no robust evidence of any predictive factors for PORT on DFS. In some greater detail, there were some presentations at ESTRO, the ESTRO meeting at the end of August, which I think are very interesting, and perhaps I put the ones in blue and green, that cardiac death relates to cardiac admission and therapy dose. So they looked at 1,200 patients who had radical radiotherapy with the regime listed there, 55 and 20, and that the mean dose to the LAD correlates with cardiac admission post-radiotherapy and cardiac death. They looked at 2 years post-radiotherapy, dose to the region at the base of the heart in the left coronary artery region and AV node would be highly significant with respect to overall survival. And then a Dutch group presented some data looking at some of the predicted toxicity of cardiac toxicity can be lessened by using protons. So some interesting why, and maybe try to avoid further cardiac toxicity. Another question which comes up in the MDT is, is there a group of patients, an expanding adjuvant immunotherapy in stage 3 chemo-RT? And 2 studies were discussed at, never able to say this, sujmalimab, which is acting anti-PD-L1, not PD-1. I apologize for that. It had less 3A disease, so more advanced stage 3 disease, more squamous cell carcinoma than Pacific. But also interestingly, they were allowed to, and they also received 2 years, not 1 year of adjuvant immunotherapy. And it's very small, but you can see that the benefit of the immunotherapy for both sequential and concurrent. And then on the right, in the what's called expanded access program from AstraZeneca, looking at patients treated with from 11 countries were enrolled in this program, and that is quite a substantial number when you look. And in that study, the median PFS was, in fact, better, although that could be from any treatment bias that, or any reporting bias that might be seen. But important, sequential chemoradiotherapy, which was allowed in just over 200 patients in the group, there was also a benefit. Sorry. Can I have the next slide, please? Thank you. So if we have early stage non-small cell lung cancer that is being treated, Zhang reported a systemic review and pooled analysis over 20 years looking at SABR versus RFA, but with many more patients, 12,000 versus 1,500 for RFA. And this is a group of patients where from the surgery versus SABR studies, but the local control rate, excuse me, was the overall survival rates at 3 and 5 years going out seemed to be better in the SABR group, with very minimal pneumothorax rate in RFA. Next slide, please. Is adding radiotherapy, both CRT and PCI, to chemoimmunotherapy in the light of the IMPALE study. And this is a poster from a very small single center retrospective analysis where they added in consolidation regime. And this is the results are in the long table. Now, I think the most important thing to 13 patients in the immunotherapy group and 16 in the no immunotherapy, where there were no incidents in the no immunotherapy group, there was some in the immunotherapy, 1 grade 2 and 1 grade 3. And I think it's very difficult, something that we all need to know and would like to know a little bit more about. And so that might be a basis for. And then finally, I think we've got to ask, what on earth do we do and where are we at with treatment relapse in small cell lung cancer? And there was a very good joint IALC ESTRO session at the World's discussing some very important topics, but I just wanted to highlight where we are with PCI. So there have been avoidance, that's trying to avoid treating the area that is most associated with memory recall and cognitive function, used in the assessing cognitive function. And an area that I think is taxing us all in our MDT is whether to give PCI MR surveillance might be possible in some healthcare settings, although I don't know if it is universally feasible, particularly in the UMR. But from that, there was discussion about the EORTC Prima Lung trial, which is coming soon, which will randomize overall survival, quality of life, and cognitive function. And it will include patients with both limited and extensive disease, and you're allowed to give an ERA. Next slide, please. So these are the questions from the MDT, and then red marks that might benefit from port. Well, no, but we need a better understanding of the cardiac toxicity. Can we expand the benefits of chemo-RT to give it? Although I have to say that more and more, I personally am using concomitant and really forgetting about sequential. Well, SABR, but we don't think we'll ever get a good large RCT to give us the answer. Can we add in RT to keep? And we're still not really clear on the best strategy for CNS and SCLC, but more evidence will be on its way soon. So,
summary of the radiotherapy changes. I like how you stuck a bit of estro in there as well. Keep your questions coming, guys, and getting them on their phone when it does. 1,500 people registered and potentially online for this event. So you're in the audience there, one of a band of large number of people. I'm going to turn to my colleague, Professor Sam Armwed, who works up in Leicester, both as a thoracic oncologist and a breast oncologist. And Sammy's going to take us to ESMO and ASCO. She told me to cut her off precisely at 10 minutes if she talks too much. And so that's what I'm going to do. Sammy.
Nice overview. Thank you for BTOG for inviting me to do this. This is a lot of slides, so please bear with me. I'll try closures. So this is the plan. They asked me to tell you about small cell lung cancer, and they asked me to cover TKIs of sexy drugs that are coming into lung cancer soon. So you can all relax. There's no practice changing presentations from what there is to come. Okay, so we'll kick off with small cell lung cancer. So this was the Atlantis study presented at World Lung. So just to give you a little bit of background on lurbinectedin, this is FDA-approved drug for second-line small mechanisms of action, inhibiting cell migration, reducing cancer-related inflammation, and then therefore inducing apoptosis. And Atlantis study, a very straightforward design looking at second-line small cell lung cancer, lurbinectedin in combination or CAV. The patients who progressed on first line were excluded. There are a number of stratification factors. This is the overall intention to treat population, and I'm afraid there was no difference between stratification factors. There wasn't any group that was leaning towards the lurbinectedin arm. And when we look at activity with lurbinectedin, that wasn't statistically proven. And then when we look at stratification factors, that was also, and of course, we all know that the farther you're out from platinum-based treatment, you're probably going to do better in the long run anyway. The arm looked as if it had less toxicity than your standard CAV or topotecan. However, that was not going to be enough for, so staying with small cell lung cancer and run with Luis, he presented a 3-year overall, David's already alluded to Empower 133, which is looked at atezolizumab in combination with platinum doublet. This one's the main study is durvalumab with platinum doublet, and then there was a second arm with durvalumab and tremelimumab seeing, and then primary endpoint overall survival. There wasn't particular stratification. The first primary endpoint at 3 years, we all saw that it met its primary endpoint at 3 years, and it's nice to see that's those two curves remain separated, and looks like the typical 3 years, 17% of patients on the durvalumab and combination arm versus 5.8% for the platinum. A 4 addition of tremelimumab doesn't seem to be a significant improvement over that of durvalumab alone. Definitely wouldn't be leaning towards the combination arm, i.e. durvalumab and tremelimumab. If you look at the leading adverse excess deaths compared to 6% on the platinum doublet arm only and 5% on with the addition of durvalumab. Definitely go for the durvalumab and platinum doublet arm. Really establishing the place of immunotherapy. All there is for small cell, and move swiftly on to non-small cell lung cancer. And you've seen this pie chart lots of times, and the slices the KRAS mutation. There isn't any update here today, but what I'll mainly be focusing on is resistance. To give you a little bit of background, so resistance to EGFR TKI is acquired resistance, which is inevitable. Utilize combination therapy here. Co-mutations may predict poor performance, poor of interest and of further research. So if we start by looking at what do we do post EGFR, and is there any additional benefit to giving single agent IO? And this shows no, there isn't. We're still better off giving what about with compared to docetaxel? And again, docetaxel seems to perform better than nivolumab in this EGFR mutant cohort. Point inhibitors like we have done for the other non-mutated non-small cell lung cancer. And that doesn't look as if that's deriving any. So what about VEGF inhibition or antibodies? So anti-angiogenics, as you know, bevacizumab to chemotherapy and atezolizumab gave a little bit of extra advantage once you progress. Drug combinations, so carboplatin, paclitaxel, atezolizumab, and bevacizumab, and that showing the anti-angiogenesis component. So on the basis of that, we had this Beverly trial, which is an Italian consortium, and presented Maria Piccirillo, and this is all just Italian centers exclusively, looking the standard arm was erlotinib and then addition of bevacizumab with erlotinib. And the thought was really that this would perhaps TKI works and perhaps some cohorts would benefit from adding a VEGF antibody. And here's the baseline here, 2/3 versus 1/3. Also the non-smokers, if you look at a higher proportion of former and current smokers in this cohort than we would normally expect. A smidgen of improvement with adding bevacizumab. However, this is not statistically significant either for PFS or overall survival. Subgroups are not predefined, specified subgroups. Looking at smoking history seemed to be a little bit of really not statistically borne out. So staying in this same theme of adding in osimertinib this time, and with the addition of bevacizumab. This was a purely Japanese effort, primary endpoint being progression-free survival. And again, if we look at the patient characteristics, we can see history again, a greater number here in the osimertinib versus bevacizumab arm, which standard monotherapy arm. So you need to bear that in mind when you're looking at the results. And again, the efficacy, definitely confidence interval crosses 1 and therefore not statistically significant. When you try and cut the data, bevacizumab doesn't seem to be adding a significant, statistically significant amount here, but there seems to be other smokers, which was a higher population in this group. And then when you look at it with regards to mutation, there isn't particularly addition to do better in exon 19 deletions, but again, not statistically significant. We all know that Far Eastern patients have more toxicity with EGFR TKIs, and they see a lot of pneumonitis with osimertinib. Of pneumonitis in Japanese patients, fairly high for single agent osimertinib, but when you add osimertinib and bevacizumab, so there must be some inflammatory component which bevacizumab seems to reduce. And again, no new safety signals, nosebleeds and proteinuria with the bevacizumab arm. Okay, so discussion here, but why we think there may be some differences in this VEGF antibody activity with EGFR mutants. And she posed whether it was the thing that sets those two groups of patients apart. And then she went through some of the other data with VEGF antibodies. Great advantage to adding in bevacizumab here to EGFR TKIs. So now we move to post-OZO. We know that osimertinib, we get a different mutational resistance mutations of mutations at 15%, or the point mutations at other EGFR mutations, of which the C797. Giving you a little bit of background to the next study, the Chrysalis study, which again Natasha Lee presented, amivantamab and lazertinib, which has already been licensed in the US for EGFR exon 20 insertions in non-small cell lung cancer. Second, EGFR TKI, which everyone is looking to for effect. And of course, if you look at the preclinical model with regards tumor growth compared to either of those agents given on osimertinib failure.
I mean, I'm going to give you a 2-minute warning.
Okay, right. Okay, so we're going to go on quickly then, looking at these two cohorts, so monotherapy and combination therapy. And particularly in the combination arm, where you're looking at 5.6 months of median time on treatment, and then 16 in the CNS, which is always important. The same study looked at another cohort, which was heavily platinum treated cohort here. And again, you know, this is very heavy treated population getting very good significant responses. So I think these are, so, okay, we don't want to miss out on these sexy drugs, the ADC. So you all know we have an antibody, which then is connected to a key problem is the linker. And there's you get to the cell, and then the cytotoxicity is released into the cell in research at the moment. And the most common one that we're going to look at is trastuzumab deruxtecan in the post. And this is the DESTINY study. So this looked at HER2 mutated cancers and giving heavily treated patients. And look at that waterfall plot. Looks like on target effect to me. And these are things that you need to look out for in phase 3 study. Just one more, and I just want to show you this. Oh, sorry, want to mention another ADC that we need to look at coming around the corner. This is looking at agnostic TROP2 expression in lung cancer. And again, these are very heavily treated patients who are getting very good sustained responses. Atlantis study negative using lurbinectedin and doxorubicin second line. Caspian study sustaining its improvement disease. We're all worried what we're going to do after osimertinib, and it looks like as if combination therapies around the corner, probably need many that can occur. And of course, antibody drug conjugates around the corner, which are intravenous. So really coming to me done, boss.
Thank you very much, Semri, and thank you for speaking through the end there. Apologies, you just want to make sure that time is equally divided, so attracting the attention. Keep those questions coming, guys, and what we'll do is we will do them at the end of the 3 talks after Riaz's a bit, so we can. So finally, I'm going to ask Riaz, who is suffering from being a bit unwell the past couple of days, so I'm extremely grateful to him, and in fact, I'm extremely grateful to all of our speakers. Let's try to work out the relevant talks, do screenshots, bring them onto here. So I'm really grateful to all my 3 speakers, and particularly Riaz, who's going to be the last and is going to take us on the final tour of the abstracts from ESMO and ASCO. Thank you, Riaz.
Thank you, Tom. Good. I just want this talk is really relevant to UK practice. So if you're not in the UK, things I may say may not sound particularly relevant. Apologies. In the UK, we're a conglomerate of several nations, and there are some differences. I work in England, and so I may say things particularly relevant to England location. I want to thank Takeda and Roche specifically for sponsoring me for registration for both these meetings. So let's crack on. Not working. Next slide, please. So advanced non-small cell lung cancer, but not really going to change your practice, so you can relax. So this is durva plus tremelimumab plus chemo in first-line treatment of metastatic non-small cell. Good performance status, treatment naive, randomized into 3 arms. At the bottom in red, we have what was considered standard at that time, chemotherapy, that was standard of care today. And the other two arms are interesting. One is the same chemotherapy with durvalumab, or the light blue. And the tremelimumab, importantly, was given for 4 treatments during chemo, and then only a single treatment thereafter, so 5 treatments. The primary endpoint was the PFS in the single agent IO, durva chemo. So the groups are well balanced. The things I want to specifically point out to you that about a quarter of patients in all the arms are never smokers, liver mets in around 20%. And this is the bottom line, the primary endpoint. So on the left, PFS, you don't change very much, the median from 4.8 to 5.5, but at 12 months, the landmark goes to 24.4 statistical significance, with 29% of patients alive at 24 months. The one that interests me, durva plus tremi, you'll see that it performs a little bit better. So this time, PFS is significant, and OS 3% alive for overall survival. You can see by histology that 41% of patients and squamous patients don't do as well, 26% alive. But I think what's noticeable is the difference between durvalumab alone and durva. Now, let's just compare it to 2 other trials. So Keynote 189 on the left is non-squamous. 5% of patients were alive on the landmark. Obviously, this is quite mature data, but if you go back to this Poseidon study and look at the histology, a 24-month figure is reasonably mature. And if you look at squamous on the left, on the right, sorry, Keynote 407. So there isn't really a sense that the figures that we're seeing in Poseidon are very different from Keynote 189 or 407, raising questions about whether this is the cost of the treatment. What about other trials of CTLA-4 non-small cells? So Checkmate 227 is the classic one where you see Nivo-Ipi compared to Nivo. There isn't much difference, but always a suggestion that the CTLA-4 component adds a little bit more. But the question, and another key study that was presented recently at World Lung last year was the Keynote 598 study in high PD-L1, well, flat as a pancake, frankly. Now, I want to park that to one side. It's an interesting study. I don't think it changes practice immediately. Interesting. So OSE 2101 is a vaccine, right? And this is a vaccine to 9 peptide epitopes combined in a vaccine. And they did this randomized trial called Atlant-1. And these are in patients who've wild type for EGFR and ALK. And they basically were randomized 2-to-1. They had to have IO as the last line of therapy, docetaxel or pemetrexed. And so it's given 3 weekly for 6 injections, then 8 weekly for a year, and then once every 3 months for survival. Now, because of the pandemic, they had to shut this vaccine study down. And what they did is an analysis of a specific subgroup of patients. So patients who had done well on IO, had had it for more than 12 weeks, and then progressed. And what you see here is a survival, quite a significant hazard ratio. Seems to work across all subgroups. So interesting, it's not practice changing for now. It's just something of chemo first, then IO, not chemo IO. So there's a question mark over the applicability of this, but I thought that was just really interesting to see as cancer. On the other thing that was interesting is they actually had good, robust evidence showing the time to deterioration in performance status was better and toxicity seemed acceptable. And then another study that I thought was interesting in post-IO was a TKI. And it's a multi-targeted anti-kinase TKI. And this is all to do with an immunosuppressive tumor stops working because the tumor microenvironment becomes IO resistant. And then the tumor starts to progress. So there's a multi-kinase TKI that targets several key receptors that are thought to be important in that process. And so in this study, it's a straight phase 2 study where advanced patients, 68 patients who have disease, get sitrafatinib plus nivolumab. And what you can see is that most of these patients had a previous treatment, and many of them have had a PR or stable disease. In fact, all of them did. And this is the swimmer's plot. And what you see, there was a durable response that went on for some time. And the PFS curve looks good, 45% of patients still progression-free. This is the OS curve, 32% of patients alive at 24 months. So very, very interesting. But basically a very interesting study, and there's a randomized study going on called Sapphire 3 that will really tell us whether this is something IO who are progressing, and we've used up all our options and we start running out, and so this is great stuff. Nice trial here, binding agent. Dublin 3 is a straight randomized trial, docetaxel plus plinabulin versus docetaxel plus placebo, 9.4 to 10.5 months. So it's not a huge change. But what was interesting is look at the 24-month landmark. Almost double the patients, 10% of patients with plinabulin were still alive. And it also significantly reduces your chances of getting grade 4 neutropenia compared to docetaxel. Power 010, I mean, this trial has had data presented at World Lung and ESMO and ASCO. The series of presentations, positive and statistically significant in their hierarchical statistical design. So this is 1 year of adjuvant atezolizumab after adjuvant. Presentations that were more recent was this, the PD-L1 split. And what you see is the maximum benefit of adjuvant IO seems to be centered. This will be as per the trial design, greater than 1%. So we have to have an internal discussion, I think, as oncologists as to whether we think someone's that's been published in the Lancet as a result of the presentation at ESMO last week. Notable that only 32% as to whether the control arm was undertreated post-study. There are lots of other adjuvant IO trials that are going to report. Quick whiz, palbociclib, straight phase 2, interesting data, median PFS of 11 months, median OS of 26 months, cancers, predominantly B3 and C. This is the waterfall plot, looks interesting. So obviously, I mean, this is a tumor site used, but here's some data showing that palbo seems to have some activity. And then there was the nivo-thyme study, EORTC, ETOPS, nivolumab, and some have got nivo-ipi. They've only presented the patients that had nivolumab. The study failed in its primary endpoint because the measure, but the success rates they found by central review was 35% and 39% by local investigator. But there is some. Moving lastly to mesothelioma, Checkmate 743, registration study, nivo-ipi versus standard chemo. We know OBA, they just presented some 3-year update of OS, and you see that it looks good. I think what's interesting is it seems that non-epithelioid seem to benefit hugely, and there's a question mark over the PD-L1 negative patients. And I would refer you to the EPAR. There's a huge wealth of information that isn't otherwise in the public domain. Look where it shows you the OS plots and the PFS plots by BFS by in PD-L1 less than 1% of patients, and you see the nivo-ipi arm really seems to underperform. So you could argue whether in histology as well, there's some interesting data with epithelioid versus non-epithelioid. All the data is in. Should nivo-ipi be restricted by PD-L1? Should it be restricted by histology? I would refer you in the same EPAR document to the 24 promising. So even despite poor PFS data, it seems to change the biology of the disease and deliver sustained survival.
Thank you, Riaz. That was a characteristic tour de force. And thank you to all of our 3 speakers. The miracle that is the iPhone. First question to you, David. Did Pacific R present results on EGFR mutations of durvalumab as we're allowed to do currently in NHS rules? Was it better than you thought? Was it a bit disappointing?
Presentation, I don't think so, but they certainly didn't present any PFS subgroups on mutation. Does it change?
What's your general view on Pacific R? Did it reinforce? Was it encouraging? Was it disappointing?
I know, I think it acknowledged, but and the important thing was that it was real world data, so you could argue that patients were maybe not as a trial, but also the numbers were very large, and so I think it does a field.
Thank you. Question about lung art. A great study, and I think really has been practice changing. Or is it just that the wrong dose was used and therefore it was causing this increased mortality? If only one could find a better fractionation.
Really good question, and I think that it is subject of that we could debate, because presentations looking at the finesse of what is actually causing cardiac death, and mapping, instead of when as clinical oncologists we just draw the heart, we and say more finessed and look at the particular anatomy of the heart with reference to the base of the heart and the radiotherapy plan, either using protons or photons, that really reduces the dose to what we are beginning to understand of the critical was significantly lower.
Thank you very much. Question for Samarine. European study, what impact do you think that had on trial outcomes? From Dr. Anonymous.
Poseidon was for...
Apologies. Well, yeah, it's Poseidon. You're quite right. EU trial. I wasn't concentrating.
Well, I mean, you know, I've done to a very, very high standard. I was surprised by the number of never smokers in it. You know, it might, exactly what I said, you know, if you could, I mean, the data's the data. I don't see how, I mean, I don't think Eastern Europeans are particularly different from Western Europeans.
Data from Caspian with the Treme arm, looking at the data you've just seen with Riaz has shown us from Poseidon, or does it still have a role somewhere?
Well, in small cell lung cancer, I would definitively say that if you're causing 10% of, would you give that when you can give a much less better effective treatment with durvalumab and chemo alone? So that's small cell. Not maybe a small cohort of patients, and it's all about biomarkers, isn't it? It's all about selection. So I'm sure there are the addition of CTLA-4, and as yet we just don't know who that group is.
Yeah, and EGFR TK have a love of erlotinib and RAM, ramucirumab, which is licensed, and indeed Bev is licensed in combination with erlotinib. Are you disappointed by the lack of OS benefit? And do you think there's anything in this genic to TKI is with erlotinib but not with osimertinib? What's all that about?
So if I just remind you about the bevacizumab versus erlotinib alone, right? So there were smokers who had advantage to bevacizumab. So you could argue whether often are the same cohort. So you don't know whether it's their phenotype or their genomic. Look at osimertinib and bevacizumab. I don't think there's any advantage at all apart from the pneumonitis risk. And this is exclusively in Caucasian populations, very much more heterogeneous in terms of EGFR mutants. We don't know whether they'll.
Right, goes on to you properly this time. First of all, someone said shout out for Sapphire trial, which the Citravatinib Sapphire Centre is there. We have a question for you regarding Empower 10, and the obvious question, which we all want to know, is you're in clinic, surgery, you've had adjuvant chemo, they've got a PDL1 of, let's say, 10%. Are you going to be offering adjuvant atezo, or is that hazard ratio of 0.8?
Yeah, well, I think this whole, we're entering a new era in thoracic oncology of this argument raging with adjuvant OSI. Look, if you're a purist, you'd say, well, without ON adjuvant treatments to patients, my experience is that you just got to have that conversation. Actually, when you sit patients down and walk them through the longest time, because they're very, very complicated about risk and is it really worthwhile? I mean, I think it's we've got a high PDL1 patient getting 1 year of adjuvant atezo, then not being able to access IO on an issue. Western world, it's a huge issue for us. So I've got huge concerns about our may disadvantage patients further down the line. But yeah, I mean, I think if the PDL1 is less than 50%, it may delay relapse, by a modest amount. And you've got to have that discussion with a patient about this is the toxicity profile. It's not an easy question to answer,
Not about it. David, going back to your SRS versus RFA study, which was very interesting, as you say, they've in the MDT, in your MDT, do you have both those modalities available, and how do you choose between them? What practically speaking is?
Well, I think the big issue regarding ablative therapies will be local availability across all 4 nations. I'm hoping that the availability of SABR is no longer an issue, that everyone who needs, until quite recently, RFA or microwave ablation or other forms of ablation, I think, are very and centre dependent. And so there are many centres that just cannot or don't have the ability to offer those populations. In our own MDT, Sabre is readily and freely available, and that is our default. RFA, we would perhaps consider it in patients' worries or have been very, it's just if they've got another lesion which has occurred in close proximity to an MDT, it's not the default ablative therapy. It's something that we would use and very.
Thank you. Maybe finishing up on you. Antibody drug conjugates, deruxtecan, that was a headline, one of the headline news in lung cancer. You were saying to us before the broadcast, massive news in breast cancer in their data, particularly in lung patients of concern about pneumonitis. Tell us a little bit about pneumonitis and tell us a little bit about how one might assess patients and how you view that.
The group of oncologists who know and see pneumonitis most, and we have the most access to, forewarned and telling your patient early on, if you get a cough, you get it first, there are early pulmonary events that these occur. So just like TKIs, you tell them about cough, give them a card to earlier with steroids and oxygen and supportive therapies. Pick it up later, the prognosis is much worse. So it's all about, responses that we're seeing. It's almost certainly going to change the paradigm for non-small cell lung cancer, the introduction of any other group, but it is higher than chemotherapy. So you've got to be very careful about that. But it's about time so they can get urgent treatment.
Thank you very much. I absolutely agree with you. I think it's fantastic data and very exciting. We hope that we will have access to those. For sending your questions through, I haven't answered all of them, I do appreciate, but we always think it's important to cut this down to an hour to keep it efficient. I'd like David Gilligan, Samri Namad, and of course, Riaz Shah. Please fill out your feedback, otherwise we will get beaten up by Dawn, and that's really upsetting. Media, Richard Belch is up for an award. So I don't quite know, Richard, how people are able to vote for you and say that you're magnificent, but there's some kind of people in it. So I don't know if you can put that on a chat or what, but we would love people to support Richard and his colleagues if you felt that they have provided a good. The last couple, I don't know, Richard, if you can share the slides just for the upcoming webinars. So we've got a couple of things coming up week after next, October. Something I think I should go to so I can learn some radiotherapy, but I think it'd be too advanced for me. And the day after, Friday the 8th, involved in the lung MDT in any capacity, whether you are chairing it or you're new to the MDT or you want to improve your MDT, that is a half-day affair, 9:30 till 3:20. So if you'd like to be part of those, then please do register. We wish you a lovely evening. Good night.